So those who have been trained that has moral obligation to this patient, they need to be carried along. We also carried out zonal sensitization of key stakeholders to share with them the report of the DEX review, field survey, situation analysis, and submitted by the consultants from the field study. We harvest their views and inputs into the repositioning drives, and wider consultation engagement meeting was carried out to share the vision, goal, and update of the PCN collaboration with MSH on improving spectrum and quality of healthcare services delivery by these PPMVs. We noticed also that most of these health services that the donor agencies are carrying out with these individuals, they carry it out across board. Whether you belong to the read and write only individuals or the retired health workers who have found their way into the PPMV landscape, or even some individuals who are engineers, lawyers, and sorry to say, doctors and some pharmacists are within the PPMV group. From my June report, you would have seen the percentage of pharmacists from the survey that are involved in PPMVs. So we needed to now identify who are who really, because you can't tell a read and write individual, you can't talk to him or her about family planning. What does he or she know about family planning? So you need to segregate these individuals so that the services you are passing on to Nigerians can be properly monitored, identified, and put to practice. Because if you think you have trained the read and write only individual whose concern is to make money, by the time you turn your back, you throw away whatever you have taught him or her and looking for the naira and kobo that brought him into the landscape. The sensitization also was to provide a platform to enrich and contribute to the strategy of repositioning these individuals, obtain their commitment and support on the repositioning project. Because we understand and know that most of them are doing what they are not supposed to do. Apart from selling drugs that is above their limit, they are also involved in all sorts of healthcare services, D&C, and all sorts of things. This needs to stop. And that's why we are saying pharmacists must take charge, must take control of whatever it is. Because by the time they are doing this evil, when press want to carry this news, they will say pharmacists, pharmacies. And it is me and you they are rubbishing. Meanwhile, we are not the individuals involved. As I was even sitting on my table this morning, a call came from my director that the enforcement that is done in one of the states, after seizing the drugs from this patent medicine, the pressure was now coming from the DPS, who is acting as the PAMSEC of the Ministry of Health, that they should return those drugs. That the Secretary of Government of that state is saying that they should return those drugs. You can see the dimension these things sometimes go. And the DPS was just pressurizing my director that they want to sack him. I said, how can they sack you? Tell them what they are doing is wrong. So a lot of advocacy and enlightenment need to be done, even to our leaders, to understand and appreciate what these individuals are doing in the pharmaceutical landscape. It's not that pharmacists don't want them to exist, but the health of Nigerians should come first before we start talking of the naira and kobo. So if somebody at the level of a secretary to government is telling us to return the drugs if the DPS still wants his job, you can imagine what is happening in this country. So it's something we need to come together and see how we can rectify the situation and move forward. In order not to waste most of your time, let me go and, I wanted to show the human resource statistics of this country, but we can't take it up. I wanted to show you the list of registered pharmacists and licensed pharmacists from 2014 to 2018. And the pharmacy technicians, their numbers from 2014 to 2018. As of 2018, we have 24,000 registered pharmacists and 13,000 that have license to practice. Pharmacy technicians, as of 2018, we have 4,682 registered and only 1,134 that is licensed to practice. And we also have the categories of licensed premises as they spread out from northeast, northwest, north central, southeast, south, southwest. And from the statistics also, we have the importation as they are spread out, manufacturing, retailing, wholesaling, and distribution. And importation, the highest, you have them in southwest. Manufacturing, you have the highest in southwest. Retailing, you have the highest in southwest. Wholesale and distribution, you have the highest in southwest. And the least, we have northeast, we have 4 companies doing importation. Manufacturing is 0, retailing is 80, and wholesaling is 86. So also the way and manner the number of licensed pharmacies is also distributed. And we have about 5,507 in southwest with a female of 2,511 and male 2,996. I just wanted to show this so that I will use it to back up whatever I need to explain. And also we have the community pharmacy, the practice area distribution also, and how they are varying in the various geopolitical zones of this country. The community pharmacies is still the highest. Those that are licensed is 8,524. And the least of all is the academics that are 236. Most hospital pharmacies don't register. They don't register. And we have been able to trace some of them as registry. But as at December 2018, 16,640 of them have come under our coverage. And this shows that the enforcement and the activities we are doing have been able to capture them and put them under our control. But however, we have really not gone far with the job. The studies conducted by PCN in collaboration with Launch, DISI, and Integrate E-Projects 2014-2018 shows the following gaps. 1, PPMVs are widely distributed in rural areas, which include hard-to-reach areas, but do not provide the needed range of pharmaceutical services. 2, there is need to encourage the spread of community pharmacies to rural areas to increase the provision of pharmaceutical care services in such places. Last week, when our staff went for enforcement in Castina, it's surprising to find out that there's no community pharmacy in Daura. And this is a challenge to us all. These young pharmacists who are coming, they're always going to the town, to the cities. But we should devise a means of encouraging our colleagues to go into the hinterlands. Being rendered in that area. So we should learn these young ones to understand and appreciate the movement of pharmacies to hinterland. This idea of once you see a pharmacy that is thriving in the town, you want to come and stay close to the pharmacy, just away. We should not congest the urban centers. We should encourage our colleagues to go to the so-called rural areas because of pharmaceutical services. Thirdly, there is need for oversight and supportive supervision for the operations of these PPMVs. We have to take up the leadership in the pharmaceutical landscape. This we have not done over the years. We need to take over. Some PPMVs have higher educational and qualifications prior to the engagement of PMS operation, which is not known at the point of registration and licensure. As at the time you are licensing these individuals, they will never tell you they are nurses. They will never tell you they are engineers, they are doctors. They will never. They will bring just their school certificate result. But these studies have shown that some of these PPMVs have higher education. That even the chairman of one of the states in the north has PhD. By the time we encounter them, we discover that they are not just school cert holders. Therefore, we needed to now separate them. Council has a definite roadmap to see how we can reduce the influence and activities of these individuals. It's not what I can share in this field, because I know, as we are all sitting here, we are not all pharmacists. Even if we are all pharmacists, there are still some of us who still have a role to play in the PPMV landscape. That when you discuss certain things, you'll be shocked that this information have gone haywire. So in order to address these 4 issues, regulatory framework and mechanism has been put in place. 1, to address and identify gaps, PCN is currently carrying out a pilot study. It's called a pilot study. A pilot study test of the following concepts. 1, satellite pharmacy concept. 2, hub and spoke supervisory model. And the PPMV tiered accreditation system. These things cannot be in operation if the law that is before the presidency's signature does not come into effect. This thing cannot, what I'm saying now cannot. Because if they are not backed by laws and regulations, we cannot operate it. So that by the time the law comes out and we want to drop regulations, the leaderships of the various technical groups must come together. We must take leadership of the pharmaceutical landscape. We must take charge of it in whatever manner. Because the pharmaceutical services that are supposed to be rendered to Nigerians is in our hands. Because anytime anything goes wrong, it's the pharmacists they will be calling all the time. When the newspapers or whatever want to carry the news, they are looking for pharmacists. Meanwhile, those who are doing the evil are using our name to trade, carrying away the financial gain. And when the evils come up, it now falls upon us. We must reject this and work out salvation for us all. I've spoken a lot about this satellite pharmacy, which I said earlier cannot come into existence without the law. This is operation of pharmacies in underserved areas, whereby the existence of such pharmacies shall be tied to an existing registered community pharmacy situated in urban or semi-urban areas. By this, the operation of satellite pharmacy shall be in affiliation to an existing and registered pharmacy. This model will guarantee the extension of pharmaceutical services through the engagement of pharmacists whose services are locked up in other various human endeavor, both in the public and private sector. And it's also an opportunity for we community pharmacists to expand. It's an opportunity for us to expand. Because what we have before us today is what you call occupational warfare. Occupational warfare is when your enemy has occupied the space. And you need to not take charge of that. Even if you bomb them from the air and you don't occupy, if they die, their children will come up and take over the space. So if you are fighting a warfare, by the time you capture a space, you occupy. If you leave it vacuum, the enemy will come back. So when the concept of satellite pharmacy is one of the weaponry to occupy the pharmaceutical space. Because it's easier for me, or it's easier for Pharmacy Council to deal with a pharmacist than to deal with a non-pharmacist. Because one, the pharmacist has emotional, moral responsibility to the health care of Nigerians because of his training. So apart from making money, the responsibility of the pharmaceutical services to Nigerians lays on our shoulders. Therefore, if you want to exhibit this in a warfare-like manner that has been occupied by individuals who don't care about the health care of Nigerians to some extent, you therefore need to step out. When you step out, you capture a territory, you occupy. Until a time will come, you have finally occupied the territory and your enemy will be subdued and consumed in whatever you are doing. Because what we have today concerning pharmaceutical landscape is a terrible warfare. While some of us are struggling to ensure that the drug we are giving out to patients is the right one, some are busy doing fake one, adulterated one, pushing into the system to make money, which I know no pharmacist will ever do that. And that is why they think we are not rich. We are rich inside. Because for every life you save, you are enriching yourself. So this is one of the tools, satellite pharmacy concept, which we believe will come to play when the bill is signed into an act, because it's already entrenched in the bill. 2, the hub and spoke supervisory model, which is a tool also. And this hub and spoke model, we know what we all have seen a bicycle. In the wheel of the bicycle, you have the hub, and you have the spoke going out of the hub. The hub and spoke model, like the hub of a bicycle wheel, the supervisor is at the center and exercises supervisory role over an area akin to that of a bicycle wheel. The supervisor is a pharmacist appointed by PCN. The supervisee, who is a PPMV, are spread around the hub within an area defined by PCN. You find out that these international organizations, when they come into the territory, they do training and distribute health commodities. After some time, they go off. Or whatever have been invested, after 2 or 3 years, it phases out. Another agency will come again, start all over again. We are telling them that this should not be so. The pharmaceutical landscape is governed by PCN with the leadership entrusted on pharmacists. Therefore, if you are coming to my local government to do something with reference to CPs and PPMVs, you must do it in such a way and manner that the CP who is within a territory, a designated territory, will take charge of the pharmaceutical services that are being rendered in terms of documentation and distribution of commodities. So that whatever has been achieved in the 2-3 years or so of the presence of that NGO will be properly documented and warehoused in PCN. So that if it is an activities the government wants to continue, PCN has the wherewithal, with pharmacists at the front, to do these things. Because over the years, once they finish, they pack their bag and baggages and they go. Another set will come again, start all over again. How many PPMV do we have here? How many this is that? They will start all over again. We are saying no. We have well-trained individuals. So PCN is taking over the pharmaceutical landscape. We are going to put up the hub and spoke model that will see to whatever activities that is being done in a given territory within the pharmaceutical landscape. That is the hub and spoke supervisory level. And we believe that the pharmacists that will be rendering such supervisory something must go with something, which can be worked out with the NGOs and let them build it in their budget, and whenever they are coming for any activities whatsoever, they should put this in their budget so that whatever they are doing, PCN cannot be there all the time. We must have a community pharmacy within that designated area to take the supervision, but not necessary to go and find out the naira and kobo they are making. So I'm rounding up. Let me just rush to the end then. So, well, we have expectations, which I've listed out. We have challenges, which time will not make me to speak on. Then we have said about its PPMV three-tiered accreditation system, which is specific to the activities of these NGOs. We are telling them, NGO, you don't just come and throw things across the board. These individuals you are dealing with, they are people with read and write mentality or qualification. You have pharmacy technicians among them, and you have others who have the health knowledge. So you exploit that to get the best out of it. However, Integrate E and CHI has conveyed their full commitment to support PCN in the pilot implementation of the tiered accreditation model. CHI and Integrate E are helping us to do a test run in some states to see how all these things I'm talking about, the hub and spoke model, is going to be effective with whatever they are doing concerning family planning and other services that they want to carry out. There's not much time, and we are having it in Kaduna, Kano, and Lagos states. The eligibility is there. There's no time to speak on that. So we want to give credit to Integrate E for their support so far, for us to see how feasible it is. The pilot study of 3 is there. And we believe that with the support Integrate E is giving to us, we should be able to come up with a result from the test run and see how feasible it is. If it is not feasible, we cross it out. If it is feasible, we can now discuss further with all technical groups and see how this thing can be implemented. If it doesn't fit to our programs, if it doesn't fit to our ideas, we have to jettison it. But however, pharmacists must take over the pharmaceutical landscape as the leaders to lead this nation out of the dread of fake drugs, drug abuse, and alcoholism in this country. Thank you, and God bless you.
Thank you, our registrar. You could see in the course of delivering his presentation, he was even undergoing occupational warfare. Many a times he was coughing. When he wants to dish it out, the warfare was reaching him. You will have to cough before he... So, the Lord is for strength. We continue to pray for you. And we hope we'll be able to capture many territories and occupy them. Not just capture and leave them like the Boko Haram people and they come back and whatever. We have been informed about the management service for health, which they have engaged, and the ARDO strategy, and of course, how we are going to occupy the whole pharmaceutical landscape. How I wish we have enough time. I don't know whether the registrar is going to be around for the town hall meeting tomorrow, because some of these issues that he has raised are very germane and worth talking on. But by and large, I think the pharmaceutical landscape has been invaded in a disruptive, innovative way. Whether positive or negative, that's for us to discuss. Our time is fast spent, but that notwithstanding, the chairman of, our chairman is here, and we also have another panelist in the house. So it's only fair to hear what they've got to say about all these presentations. I know my chairman, if you give him time, he can talk from now till evening. So, Mr. Chairman, I'm the chairman here. So, I will chairman you if you are not conforming to the time allotted.
All right, thank you very much. Let me appreciate the chairman of the occasion, of this session, and appreciate all my panelists, especially appreciating our registrar, able registrar. You recall that registrar has been working with us. Like I told you earlier yesterday at the opening ceremony, we have never had it this good. I'm sure you have not forgotten our universal MCPD that we have come to initiate and has come to stay as pharmacy in Nigeria. So it is courtesy of the registrar. I think it deserves an applause. My job is very simple, and I'm going to show you that I'm not going to take time at all. First, I would like to thank especially the partners who are here. I want to recognize pharmacist Emeka Okafor of Society for Family Health. Thank you very much. That's the manager of Integrity Project. Pharmacist Suleiman Sule, Feed Intelligence, Chef Life. You're welcome. Mahamadou Abdulatif, Everyone Mobile. You're welcome. Thank you. Mopa Esunga, USP PMQ. You are welcome. And our Hawkins partners, you are all welcome. We actually invited well over 50 partners and donor agencies for this section. However, and let me even say that close to 30 of them replied with affirmative of their interest to attend. But what happened now, I cannot tell. But I know certain things happened within the course of time. I just want to say to us, what exactly is the basis for this section? It is novel. It's probably the first time we're having this type of session. Okay. Oh, thank you very much. Another person that joined us, Sheyi Gansilo, Clinton Health. You are welcome. Thank you very much. Yes. My responsibility at this time is just to let you know what informed this and why we must do this. And I believe that this type of engagement will certainly continue. For us, as a people and as a leader of this group at this time, we believe so much in collaboration. We don't believe too much in silo operation. We believe that it is in collaboration and cooperatives that we can leapfrog and move to the next generation. And since we've identified this set of individuals as players in our landscape, and we know they've been doing so much activity with us, we felt that there probably will have been reason or concerns, either of satisfaction or some level of dissatisfaction, either on the side of the community pharmacy as provider or at the side of the supporter, the partners. And we felt that, okay, it is good enough for us to come together. One critical thing we have been able to put on the table is the fact that were the training that were being given for some of these services, were they enough? The length of training. Are people being trained enough to deliver these services? Based on some of the feedback we are receiving from some of partners that they are not satisfied, you can see from our survey, which is what we felt that whatever we want to do, let us be scientific. Let us carry out research from both the side of the partners and from our own side. That's exactly what informed that research. Unfortunately, we do not have the luxury of time because we didn't start in good time. And for this, we might not be able to discuss as much that we would have loved to do. But I hope that whatever the little time we have, we can be able to bring out some deliverables from this session. So, on this note, I want to welcome everyone to the session. We move straight. We'll just take perhaps maybe about another 30 minutes with the permission of the chairman, because some of our other speaker and panelists for the next session have flight to catch in this afternoon. So I want to beg, maybe in another 30 minutes, we can wrap up this session so that we can move straight to the next session. So I promise you that this type of engagement will continue, and we will have more time, even within the year, to engage so that we can hear ourselves out and ourselves better. I want to thank you for listening. Thank you very much.
Malaria? Lock it down.
Thank you, Chairman.
Lock down malaria with Lockmal Combi. Lockmal quickly and effectively clears malaria parasites from the body and makes you malaria-free. Lockmal Combi, a brand of artimethyllumefantrine, comes with 12 bonus tablets of Emzor paracetamol. Lockmal, lock down malaria and feel even better.
The family of a corn has been taken hostage by an evil-looking creature.
When Amatem Fort appear, malaria around for cover. Amatem, thank you. Amatem Fort are just some gel capsules, tablets for adults, and suspension for Pekin. Amatem does not eat somebody and are very easy to use. Remember how Amatem Fort against scratch pin to confirm the original and against some gel capsules. Amatem, say no to malaria, yes to life.
The family of a
before they move to other levels of health care. They are the best in terms of care and counseling. They have listening ear to the patients. I know why I'm taking this time to explain this. They are a kind of an intermediary for referrals, because the pharmacist will see the client first, screen them, advise them, educate them, and do the referral that is necessary. The pharmacist is also very good at documentation for your programs. They are genuine, they are honest, they are responsible, and all the records you need will be given to you. So I think, because in so many programs that I run, I know that if you involve the pharmacists, the people that are key, they are the closest to the people, they'll be able to deliver more on some of our, especially family planning services, immunization, malaria, TB, and so on. As a pharmacist, she's in the best position to do immunization. And then for the parts of the pharmacist, if you involve yourself in these things, one, it could be your social responsibility. It could add to your business. Taking, for instance, immunization. I had the privilege of talking to some pharmacists about immunization. You can decide to do immunization in your state. All you need to do, you don't even need to buy it, because vaccines are free in Nigeria. All you can do is to meet with the Ministry of Health in your state, the officers in charge of immunization. They give your nurses, because pharmacists, I know we are not supposed to use syringes and do all the injections, deliver any injectable commodity. But we have nurses in our facilities. So if they're able to come, they'll train your nurse, and you have the vaccines in geostyles. Then you can do outreach. People will begin to come to your facility. They will not only take the vaccines, but they will also buy drugs from you. They will have confidence in you. They will trust you. They will connect you in other areas. So this is a way of also expanding your business. You can also help in family planning services. In our state, there is this program they do where the pharmacies can form a hub and scope with the hospitals. After training them on long-lasting reversible contraceptives, they can now form, the hospital will form the hub, and the pharmacies around will be giving reports to the hospitals. So in that way, you can also leverage on such programs. I know the latest DMPA subcut injection for family planning. If the individual can give it herself, why can't the pharmacist do that? So I think we should begin to be more proactive when things come on board. For instance, the task shifting, task sharing policy. I don't know how many pharmacists here are involved in it in their states. It's ongoing now. A lot of states are domesticating their own. Are we proactive there? Are we making, are we giving solutions? Are we making our own contributions? When this is now done, we begin to ask questions. But now that is in progress, just like the registrar said, please let us be part of it. And also let us expand, like he said, to how to reach areas. There are so many ways. I think the pharmacy should begin to be more proactive. There are so many programs. There are so many IPs invited. How many implemented partners are working with pharmacists? I keep asking this. Apart from FHI, how many implementing partners are really working with pharmacists? Do we know that I can reliably tell you that some of them are even working with PPMVs and not with pharmacists? So I think we have to be more proactive in this area of public health services so that we can also benefit and do our own quota in this area. So I implore the partners to see how they can involve pharmacists in some of these things, because if I tell you that they will help you improve on your indices, your goals, you will achieve more involving the pharmacist in anything you do, you will know that I'm speaking the truth. So on this note, I want to ask the pharmacists to please see what they can do to do a lot in malaria. You can screen the patients. If somebody comes to you every day is down with malaria, there's so many things you can do. You are the best person to know whether there's drug failure. You're the best person to advise on use of LLIN. You're the best person to advise on even the use of drugs. We're talking about resistance and so on. So we can involve in HIV. We're already doing that. But then let us think in the direction of immunization, family planning, TB, and so on. Thank you very much.
Thank you. Thank you. Thank you. The time is fast spent, but our international agencies and donor partners are here. It's only fair to give them maybe about 75 seconds each to talk to us. And with that, I'll be inviting pharmacist Emeka Okafo of SFH. Please, you have. So, from the next 75 to 120 seconds.
Okay, good afternoon, distinguished colleagues, and good afternoon, the chairman. I don't know what I can say in 75 seconds, but suffice it to say that all that needs to be said have been said. The registrar mentioned the Integrate E project, supporting PCN to roll out the tiered accreditation system as a pilot in 2 states, Lagos and Kaduna State. And all the project is intending to do is to provide evidence. Does this work? Is it not working? Is this scalable? Or do we need to trash it? The second one again is the Integrate E project is also working with community pharmacists to train them on expanding the scope of family planning services they are providing. And in doing that, we are training community pharmacists in long-acting methods, implants, and injectables. We are also going to train about 411 community pharmacists in Lagos and about 184 community pharmacists in Kaduna State. But again, before I hand over the microphone, I need to also say that we have only been able to achieve about 50% of our targets, mainly because a lot of community pharmacists are not coming out to be trained. We have invited a couple of them, engaged them at various levels, at the level of the regional ACPN level, the state ACPN level, and then the national ACPN level. And I want to use this opportunity to say the only way we can continue to advocate for inclusion of community pharmacists in the bouquet of primary healthcare services that is being tax shifted is when community pharmacies begins to provide and make themselves available to be trained. And not only trained, as they are providing services, document those services. We do a lot of things in community pharmacies. I was talking to a senior colleague. An average community pharmacist sees about 5 under 5 malaria cases every single day, at the very minimum. And in a year, provides treatments to about 1,500 under 5 in our community. By extension, we have about 8,000 community pharmacies. We are talking about close to 10 million children under 5 being catered for, but there are no evidence. So we need this evidence to be able to meet with government and advocate for a lot of things for community pharmacists. So I want to plead with us. We have an opportunity in this pilot, and I will not want to stand before you in the next 2 years when the project will be ending to disseminate and tell you that community pharmacists have not been able to do X, Y, Z because there are no records. That would be very shameful. So I want to plead with us. Let's engage. Let's be available. Let's get trained and let's document. Thank you very much.
Thank you. Thank you. Thank you, SFH. And the challenge to the pharmacists in Lagos, it is true. Many people are not turning up for the training. So the leader in each zone needs to take note of this. They want to train 400 community pharmacists in Lagos. I attended one. They were expecting about 70. Only 25 serviced. So the likes of pharmacists, Ugu of Festac, we may have to charge him with responsibility to make sure that that area is taken care of. Let me invite pharmacist Suleiman Sule of the field intelligence. 90 seconds to 120 seconds. The time is starting now. 1.
Good afternoon, senior colleagues and pharmacists present in the House. So I would like to quickly just follow up on some of the conversations that we've been having here. The imperative now is for pharmacists to deliver value-driven services. But at the back of that, we know that pharmacies alone exist as a going concern. So there are a myriad of business challenges that prevent some of these services from being delivered. In a survey we did in just Abuja, looking at 120 pharmacies, what we found out that the top 5 challenges we had was access to capital or finance to provide the scope of services we would want to. We found out that a lot of pharmacies spent 15% of their work week in procurement and logistics related activities, going to the wholesalers, dealing with reps. We also had challenges with inventory management, and inventory management in the sense that inventory accuracy was key. You are either procuring drugs in excess, so you are running the risk of expiries, or you are procuring in little quantities because you are trying to conserve capital. So what we did at Shelf Life was to come up with a service that could blend all of this support into one and provide it to community pharmacies. We're also working with SFH Integrate E to see how we could expand this. The major concepts in Shelf Life that I've described so far in addressing this has been 2 things. The first is outsourcing. So we are focusing on the clinical services and other value-driven activities we could deliver, and outsourcing the other secondary back-end functions. The second bit is we are trying to mainstream something called the subscription-based vendor-managed inventory. And by that, it means, for example, you could have someone curates a list of products across therapeutic areas. Family planning is one of that. Malaria is one of that, another one. You could subscribe to either of these bouquets, and this company, Shelf Life, we will take care of making sure that these products are always available on your shelves in the right quantities, helping with the documentation by making sure that every week, this was what was sold, and most importantly, you pay for what you sell. From the perspective of sustainability, a fee for service is being charged. Because what investors or what donor partners would want to know is, these services exist long after we pull out. So these are the kind of initiatives where we would crave the indulgence of our colleagues and support us in mainstreaming it. We have a stand in the exhibition area where we are willing to talk to people about this. We are currently in Lagos, Abuja, and we are planning on Nasarawa. Of course, we've talked about this queue of where pharmacies are located. Lagos, Abuja, and then the satellite areas around them, the southwest and south-south zone. So if there's more information, I will be available at the booth and we could talk more. Thank you.
Thank you. Thank you. While I'll be inviting Masood Abdulatif, everyone mobile, as it's coming up, your 90 seconds to 120 seconds start now. A trustee of SFH walked in to back up SFH claim, and he slipped into the corner there.
Pain?
So,
Emzor paracetamol. Feel better. Do better. Pain? Emzor paracetamol. Feel better. Do better.
We are very much happy to be here today. Everyone Mobile primarily builds digital solutions for development agencies globally. So we have projects ongoing in Nigeria, in Kenya, in Tanzania, and a couple of other sub-Saharan African countries. What we're passionate about in Nigeria is to ensure that we can strengthen the public health system, and doing so leveraging technology. At the moment, we work on the Niger Care project that ensures that we provide access to digital learning, inventory management, and a whole lot of data services for the PPMVs. So, I mean, not to say that we are not happy to work with the pharmacies, but the funding we got from the Gate Foundation essentially focuses on the PPMVs. But we have a component that serves pharmacy, and that is the mentorship. So we have pharmacists who mentor PPMVs on our platform, provide them with content that is specific per their tiered accreditation. And for our next phase, we are partnering with Integrate E to ensure that PPMVs who are on the Niger Care project are PPMVs that are recognized, approved, licensed by the PCN. And this ensures that PCN can be able to get more PPMVs to register and renew their licenses. We also serve as an avenue to ensure that practitioners are able to have proper documentation of their activities, leveraging technology. And this helps us to be able to report back to the donors that what we're doing is yielding results instead of collecting data manually. What I will now say is that as we are happy to continue to work with the whole community, especially focusing on the community pharmacists, it's our appeal that the community pharmacists become more receptive. In a project we've worked on in the past, it was difficult to penetrate into the Acpn sphere, especially in Lagos. It was difficult to get members to get the list of members and to get to even present to the leadership, to even present to members at some of the programs. So we want Acpn to be more receptive to donor partners.
We will be more receptive as from now on.
All right, so we are happy to hear that. Okay. Thank you so much, everyone.
Thank you. Thank you. USPPQM, Mopa Ezuga. $90 to 120 seconds.
Malaria. Lock it down. Lock down malaria with Lockmal Combi. Lockmal quickly and effectively clears malaria parasites from the body and makes you malaria-free. Lockmal Combi, a brand of artimethyllumefantrine, comes with 12 bonus tablets of Emzor paracetamol. Lockmal, lock down malaria and feel even better.
Issues related to medicine's quality. And how do we do that? We have a four-pronged approach where we carry out our activities in most of the countries where we are located. We work with all stakeholders, actually, in country, the regulatory agencies, the national quality control laboratories, the manufacturers, And then we have also gone beyond that to also go into curriculum development, because we also want to go to the crucible where we can have ready-made professionals, pharmacists, pharmacy graduates that can actually fit into all these areas of pharmacy practice, including supply chain and so on and so forth. Having said that, the new leadership of the Association of Community Pharmacists, we have been engaging. We had a couple of meetings, and we believe that we are going to go into more collaboration at that level. A quick win for us here that we see is in the area of post-market surveillance of products, because that is key. If those products come out of the market, from the factories, we want to see how they do in your shelves. We've done several today. Between us and NAFDAC, we've done 7 rounds of anti-malaria quality medicines monitoring within the country. And we have also done for maternal and child health care products. The last time this came up, we had a dissemination to stakeholders. And I also want to appeal to Community Pharmacists Association too, that we want to see the numbers in such dissemination forums so that you can take home to your members to see areas where quality can be better monitored. You can't take out the quality of medicines from health outcomes. Having said that also, I want to, apart from program point of view, as a pharmacist and a concerned pharmacist, a lot has been said here today. I want to see a situation where we will come up with not just resolutions. I was happy to hear when the PCN registrar was saying they already have a roadmap to address it. Beyond those things, we must have a monitoring and evaluation component where in our quarterly meetings or annual meetings, we can say in 2019 we made this, thus far we have gone. So if not, this meeting will just be more like what
Chairman,
we call holding talks.
Please note that.
We don't want to be holding talks.
In 3 months' time, we want quarterly report.
Yeah, so that we don't just post this on our website. Achieved. And then in the next year again, we'll have a program like this. There's no reference on achievables on the deliverables that we have.
Okay.
Thank you.
Thank you so much. Thank you so much. Clinton Health Access Initiative, Seyi Gensalo. 90 to 120 seconds starts now.
Thank you very much. Good afternoon, all. At the Clinton Health Access Initiative, we believe that we need to build the capacity of community pharmacists, and I'm sure other development partners also think the same. And one of the things that we've been doing to achieve this is to work with the Federal Ministry of Health to put in place policies to allow community pharmacists to do more. And I know the registrar of the PCN mentioned the tax shifting policy, and there's a document that's put in place, approved by the FMOH, and in that document, there are some specific tax that the CPs can now actually provide in the premises. I have a soft copy of that policy, and I'll be willing to share with the organizing community. It's something I think every community pharmacy needs to read and look at it, so that you can all understand the new role that the FMOH expects us to play. In that policy, initially, we pushed CHAI and some other partners too. We were thinking that for FP, rather than asking community pharmacies to counsel and refer, there are certain services we feel community pharmacies can provide because they are well trained. Things like the injectables and the implants. But in that policy, the implants was removed, but the injectable was retained. It's there. So one of the things we are now doing in CHAI is to see how we can also work with the PCN to pilot the provision of injectable contraceptives and implants among community pharmacies. And we are working in 3 states. So in 3 states, we'll be training 25 community pharmacies each. That's in Kano, Kaduna, and Katsina. And we believe that the report of that pilot, will also be presented to government. And hopefully, we think maybe at the next revision of the TSTS, the implant services provision could now also be included for community pharmacies, judging from the reports that we get from that pilot. Thank you very much. We're also going to be supporting PCN too with the other intervention. The PCN register mentioned the pilots of the tiered acquisition model, the urban spoke model, and satellite pharmacy model. We'll also be working with the PCN to also pilot these intervention in our program state.
Thank you. Thank you. The next plenary section will be coming up in the next 5 minutes. But before we round up here, we want to take 1 or 2 comments from the audience. And just for 60 seconds, 1 or 2 comments, 60 seconds. You have a correction to make? Noted. The chief, our professor here will do it. Don't worry. We are very much aware of it. So it will be done. 60 seconds. I don't know. One from this side. Okay, one from this side. Okay, 60 seconds. Come, Aminu. 60 seconds. Starts now. Take the mic there. Don't walk far. Take the mic there. 1, 2.
Yes, please, the audience. I just have a comment to make about the requirement, this one to the registrar, the requirement for PPMVL. He said when they applied, they wouldn't know they have other qualifications. But the requirement that is in the law is 1927. And probably they thought if they present the new qualification, probably they may not be considered. So I'm recommending that that requirement should be reviewed so that appropriate persons can consider it.
Thank
I also
you.
want to make
Noted.
a comment about the policy document that the registrar also mentioned. I want to inform that the registry is the gap between the practitioners and the Federal Ministry of Health. So I feel it's the responsibility of the registry to make sure that all informations that are in Ministry of Health to descend to the practitioners. That is the second one.
Noted.
The other one is...
Noted. Please reserve the others for town hall meeting.
Okay,
the registrar will be available.
Thank you.
Chairman Programs Committee. Your 60 seconds starts now. 1.
Thank you very much, distinguished colleagues. This has indeed been a very interesting session. And unfortunately, the time allocated seems to be too small for this. I bet you we can spend a whole day discussing on this, most of the issues you have thrown up. My concern is actually to the IPs, you know. I think going forward, we should be concerned about sustainability. Because what happens is that many times, these guys will come around, you spend like 5 years, 6 years, 3 years, round up your program, and then you exit. And that is the end of the whole intervention. So, please, going forward, I think you need to start letting the association, working with them better. Let them take ownership of this program, that even when you are out of the space, we can continue to roll with whatever ideas you have impacted us with. That is very, very germane.
Thank you. Thank you. Former Chairman Abuja. Chief Okoli, I overrule you.
Standing on existing protocol, my question is to the development partners. I'm just wondering why most of the pilot schemes do not include FCT, in as much as we occupy a very important place in the country. Thank you.
You are cosmopolitan. That lady in green. Wait, that lady in green. 60 seconds. 1.
Okay. Please, I want to ask the PCN about regulation of PPMVL. I discovered that when we were involved in inspection, it's only the only thing, the emphasis was if they have registered with the council. There was no emphasis on what they are supposed to stock. So I want to know, is there, are they allowed to stock everything? Has the law been changed? And secondly, I also want to ask why the international partners, their pilot studies, they don't remember states like Kebbi. Because when they are accusing other community pharmacies of not going to attend the trainings. We are ready to attend the trainings, but we are not
Okay,
involved.
noted.
Thank you.
Noted. Anybody from here? If nobody from that, then I will take Biola. Please bring it to, because chairman's immunity. It's my neighbor. 60 seconds. Starts now.
Thank you very much, Mr. Chairman. But I have questions for virtually everybody
we can
on
only
the panel.
take one.
But let me take one or two. On practice research, sir, Professor Larry Bale, how can we as community pharmacists engage more in evidence-based practice research? I must commend you, sir, for every presentation you did during this conference so far. You gave us some statistics. How can we as CPs do more of that?
Our
Please,
professor will
Albert,
do justice to that.
Pharmacist Albert Udo,
Okay.
you just put primary care. What is the extent of primary care we're talking about for the CPs? I want to know that. Okay. And please, I must ask my registrar, please, what provisions of the law are available for the breaking of the seal of the PCN? And how rapidly are we positioned to tackle these people that break seals and add one turn to the practice?
Yeah, thank you. Thank you all. Thank you all. We are gradually moving to the end of this section. Our professor has one comment to make. And while he's making that, I will invite the chairman of PSN, River State, to come and help us thank the panelists here. You come and help us thank the panelists here. And now work in conjunction with our MC to invite the next panelist to come and take over the second plenary session. Over to you, sir.
The first correction is as it relates to the Howard University Global Initiative. The truth is that they are behind the Family Health International at the same time. So when we combine, what is the name of the NGO affiliate? The Family Health International has 12%. The Howard University Global Initiative, by our finding, had about 9%. Combined is about 21 to 22%, because they are behind the two projects. But I must also state, as a statistician, you cannot change the wordings of the respondents. And so this is the way they understand it. It's also a kind of feedback to you that the respondent must therefore understand who is the ultimate sponsor. Maybe you call it a particular name, but you are behind it, you should brand it so that they will understand that it's an integral part of your program. But I'm doing this because we have responsibility towards you as our own customer as well. Good. The question from my sister, who happens to be my neighbor as well and my mentor in community pharmacy. So evidence-based research is crucial. The pharmacy as a profession has a lot of talents, and there are people who could do a lot of things for the community pharmacies. But the executives and the practitioners have to find them out and utilize them. So when my chairman, I'm not talking of my temporary chairman now, I'm talking of a permanent chairman for 3 years, Adekola, when he approached me and said, this is what he wants me to do, I didn't have an option there to get it done. And I believe with people like you understand the value of evidence-based work like this, we can only do more. And it is in doing this that the partners will also be happy with us and other various stakeholders, including government. And I must acknowledge openly here that the Pharmacist Council of Nigeria, along with Integrity E, also engaged our services to be able to get some evidences as to how to add value to the services, to pharmaceutical services in our country. God bless you.
Thank you, sir. Our job is done. You have been a beautiful audience, but to give the vote of thanks is pharmacist Chima, and we will use that opportunity to thank our panelists and make his comments. And I hope the panelists for the other second plenary is going to. Thank you.
Our distinguished chairman, very distinguished panelists and discussants, very esteemed colleagues, fellows of the profession, past president. I want to thank all of us. It's been an engaging session this morning. We're entering the afternoon. And I want to say that our challenge as community pharmacists will continue to be on the front burner, whether we like it or not. And I want to urge our registrar to please step up the game, sir. You are doing so much already. But I wouldn't want to leave here without asking our registrar, sir, to please let us begin to implement the patent list for patent PPVML. Most of the time we talk about patent medicine vendors and the list, but we don't really effect or enforce those lists in terms of what they do. Going forward, I want to thank all of us. I want to say it's been an engaging time. We will be living here with a lot of feelings, good, bad, ugly. But at the end of the day, community pharmacy is better for it. Thank you and welcome.
The double prophet just whispered to me that he wants to put anointing on top of it so that everything can seal. So, our double prophet, Elijah Muhammad, we are bowing down for your anointing.
The chairman, yeah, I just want to put records straight concerning issue of stock. We always complain that when we go for enforcement, we don't, they sell above their limits and other things. By law, the existing law that is on ground does not permit us to pack stock. I hope I'm clear. Because if you carry anybody's stock, there's no law binding, covering you, and they can sue you. The stock that is there is for NAFDAC to come and carry. And that's why I always emphasize the 4 Ps in the pharmaceutical landscape. You have the practitioners, you have the premises, you have the practice, and you have the product, all around the overall P, which is the patient. The issue of drugs, which is the P, excuse me, is domiciled with NAFDAC. So if we are to close down a shop and pack the stock, we need to invite NAFDAC to come and do that. So if we come, it's the 3 Ps, the law we are having now enables us to do. And that is the shortcomings concerning the law on ground. But however, this has been addressed with the bill that is before the president. So not until that is signed, we can only insist. So what we'll do is to pick samples and probably prosecute accordingly. But we still find out that the laws we must follow the law to be able to prosecute. I have just given an instance now. Just the samples we took, you could see the vibration within the system. But that will not stop us from doing whatever we are doing. But once the new bill comes into play, we will do the needful. There are some states I know that the enforcement, when they are going, if the NAFDAC personnel in that state is available, is not engaged, they go with them and they help us to deal with stock. And that is the situation. And that is a shortcoming in our operations for now. Thank you.
Thank you. Now invite the MC to, our session is over. And I know the chairman for the next session is around the clock, so please invite them.
Thank you, the panel of discussants. And we have all been wonderful audience. Can we give them a hand of applause again?
The family of Acpn has been taken hostage by an evil-looking creature.
When Amatem fought appear, malaria around for cover. Amatem, thank you. Amatem fought against some gel capsules, tablets for adults, and suspension for Pekin. Amatem does not eat somebody and are very easy to use. Remember how Amatem fought against Acpn to confirm the original and against some gel capsules. Amatem, say no to malaria, yes to life.
The family of Acpn.
Malaria? Lock it down. Lock down malaria with Lockmal Combi. Lockmal quickly and effectively clears malaria parasites from the body and makes you malaria-free. Lockmal Combi, a brand of artimethyllumefantrine, comes with 12 bonus tablets of Emzor paracetamol. Lockmal. Lock down malaria and feel even better. Malaria. Lock.
Thank you, that's done. Please quickly, the next session is on management of drug abuse. And the chairman of the session is pharmacist Ike Uwu, Fellow of Pharmaceutical Society of Nigeria. Please, sir, can you come to the high table? And we have speakers. Permit me to introduce Dr. Ibrahim Abdul, Kano State NDLA Commandant. And he is the chairman, ECOWAS Drug Harmonization Committee. Okay. So joining us up here is Dr. Monica Elimuzenze, FPSN, Director, R&P NAFDAC. Please, Dr. Monica, I think I'm not pronouncing the surname very well. Oh, sorry for the murdering of the name. I apologize for murdering that name. I will get the right correction. I will come back and do it. Equally joining us is Dr. Babatunde Fadibe, Suicide Research and Prevention Initiative. Jensen Pharmaceuticals, are you ready? Are they ready? Please, can you come for your presentation? Please, colleagues, can we sit down?
Good afternoon, everyone. The chairman, all protocols duly observed. My name is Pharmacist Jufa Nuhu. I work with Johnson & Johnson, the #1 largest pharmaceutical company in the world. Johnson & Johnson actually has 3 different groups. We have the medical devices. We have Janssen, which is the pharmaceutical wing of Johnson & Johnson. Then we have the Johnson & Johnson OTC consumer, where you have the Benylin, the baby product, the baby powder ranges. Today, I'll be taking a few minutes of your time to talk about the advances that we've made in cough management. Next slide, please. And the solution that Benylin would provide. Next slide. Some of the common causes of cough, as you all know, ranges from asthma, which is inseparable with cough, to viral and bacterial infections, smoking, medications, side effects of some medications like the ACI inhibitors is basically cough. Next slide. Well, basically or broadly, there are 3 types of cough. Okay, there are 3 types of cough. The wet cough, the one that normally comes with excessive mucus production or phlegm. Then we have the dry cough, which has little or no mucus production. Then the non-specific cough that has a combination of dry and wet. Sometimes the patient will start having a dry cough. Before you know, something will start coming out. So, Johnson & Johnson has a wide range of Benylin to tackle each specific cough. As you all know, a lot of pharmacists' practice has been shifting from polypharmacy, from non-directional pharmacy treatment to specifics. Today, instead of combining a combination of different active ingredients for dry cough and wet cough, you will only have what you only need to treat dry cough or wet cough, or a combination of different symptoms. Next slide, please. Changer is not working. So, the first thing you normally encounter in a pharmacy when a patient walks in, they will tell you they have a cough. What type of cough do they normally come up with? Some of the questions you normally come across: do the cough exacerbate when the patient wakes up in the morning? Do the patient have mucus production? Or is the cough just irritating and dry? Whichever the case, we have different ranges of Benylin. We have the Benylin wet cough mucus. We have the Benylin dry cough. We have the pediatric, which is tailored for patients, for children that have dry cough. Then we have the original, which I believe each and every one of us here have in his or her pharmacy because it's one of the oldest cough syrup that you... So what's new in Nigeria? We're talking about advances. Today we have Benylin children wet cough, which is the newest of all the SKUs that we have, of all the ranges. And a lot of people will be wondering what is new or what's specific about this cough syrup. Benylin children wet cough actually contains guaifenesin, and is sugar-free for patients or children that you think they can't tolerate alcohol. It's also alcohol-free. It's also colorant-free. And it has been in existence since the 1500s in the United States, so you can be guaranteed of the safety in children. Benylin is given 5 meals 3 to 4 times daily for babies between 2 years to 12 years. Benylin for flu is another newcomer to the market, the Nigerian market. We received NAFDAC approval for this early this year. And as at this morning, as I'm talking to you, we have Benylin for flu in the market. Benylin for flu is actually, we call it the for flu because it has 4 ways that addresses your patient's concern. You have a patient that comes with cough, has cold, is having fever. The first thing you think of as a student back in school, I remember you start thinking of how to give something for the cough, something for the cold, and another for the fever or pain. In this case, Benylin for flu gives you a one solution that will tackle all these 4 problems in just one bottle. So, like I said, 4 powerful 4 ways action, which 8 adherence. I think if there's any #1 advocate of adherence or compliance, should be us, the pharmacists. And community pharmacists, especially for cough syrups, which are OTCs, I think it's our role to ensure that we help our patients to take their medication. Then another research that was conducted in 2009 actually shows that most of the people that come with cough, together with cold and pain and fever, they normally have restless nights. Some of them will feel like something is wrong with them, totally out of this world. I've seen a patient that ordinarily he will tell you that I feel like I'm having depression or something, all because the cough will make you lose so much energy. I think the research proved that 99% of these patients, they feel very tired. They also feel that they lose so much energy. And how do you tackle this case? Benylin for flu will give you all the 4 ways of handling this group of patients. It will relieve the symptoms of cough. It will give them the sedating effect that they need to rest. And it will also give them the relief from pain and fever, as well as the congestion that they experience in their nostrils. So the doses of Benylin for flu is 20 mils 3 to 4 times daily. Benylin for flu actually contains diphenhydramine, pseudoephedrine, and paracetamol. So please and please, if you're giving any patient Benylin for flu, no need to add any painkiller, paracetamol. Then we have the children wet cough, like I said. It contains guaifenazine. Guaifenazine is not new to the market. However, we have a reduced dose for this particular Benylin, and it comes as 100 mils SKU. So you can give it to a baby between 2 years to 12 years at a dose of 5 mils, which contain 50 milligrams of guaifenazine. Contraindication. As you all know, multinationals, we don't hide anything from anyone. If there are concerns, we raise them, and we try as much as we can to address them. If you have any patient that is taking monoamine oxidase inhibitors, you can always avoid giving our Benylin. If there are patients that are hypersensitive to any of the active constituents of Benylin, please avoid, and if possible, report for adverse event reporting. Patients with severe liver functions, patients undergoing anesthesia, halothane, cyclopropane, please consider this group of patients. So I'll give time for questions if you have any. Benylin for flu is actually new, so we expect people to ask a lot of questions on this. Questions and comments? Thank you for listening. Remember your Benylin, #1 cough syrup for cough and flu.
Please visit your stand and patronize them. Thank you.
Good afternoon, fellow pharmacists and our distinguished guests. I consider it a big honor and privilege to serve as the chair for this session, the session on the management of drug abuse. And it's my pleasure to welcome each and every one of you in a very special way. If you look at the program, you know that I wasn't supposed to be the one to be here. But we are talking about disruptive, innovative approach. So I am one of the disruptions that you're already getting. Instead of having the past president, Azubike Okwo, fellow of FIP, sharing this occasion, suddenly you have Ike Ugu, and I am very pleased to be one of the disruptors. If you also look at our lineup today, we have, first on the list, Dr. Monica Imunjeze. Everybody knows Monica, and everybody loves Monica. And honestly, if our regulators are like Monica, then we won't have any problem with working with regulators. She's representing NAFDAC, and she's a panelist and one of the speakers in this session. I'll also like to introduce the one by my right, another doctor, Dr. Ibrahim Abdul, who is the Kano State NDLEA Commandant, and then has a big position as the chair of ECOWAS Drug Harmonization Committee. Join me in welcoming Dr. Abdul. And then Tunde is not here, but then we have another speaker, Dr. Babatunde Fadikwe, who is of the Suicide Research and Prevention Initiative, SOPIN. And then you find out that you just have Aikugu, who is not a doctor, and then is the chair for a panel that has 3 doctors. That's another disruption. And so I'm very happy to serve you today. Now we have the 3 presenters, and they will take time each and every one of them to make their presentation. Because of Dr. Ibrahim Abdul, who is the representing the NDLEA, has a need to leave us as soon as he can make his presentation. So our first presentation is going to be from him. And yes, the theme of this conference is tackling drug menace in a disruptive, innovative way. I don't know how many of you remember the cartoon character called Kole the Menace. Menace. So the word menace, the word tackling. So you wonder whether even drug abuse is a disease or is not something you have to wrestle. And I am not too certain that it's a typical disease that we can just manage. Like if you had communicable diseases or you have non-communicable, you have diabetes, for instance, or hypertension. And that's why we are using the word tackling. I am not going to preempt what they want to say, but it would be nice for us to listen attentively and to hear them. And one goal that I have for myself today is to be sufficiently committed after this program and sufficiently informed that I can take a personal responsibility to be part of the solution. And so I wish that all of us here need to listen attentively and participate so that we can become, each of us, advocates for the solution to the problem. We live in a country where our burden for the wrong things is always higher than we should. And then our credit for the right things is far below what it is. Unfortunately, also, we are in Kano, for instance, where the burden of drug abuse is far higher than it should. And so we are in the right place. Ladies and gentlemen, please join me in welcoming Dr. Ibrahim Abdul, the Kano State NDLEA Commandant and Chair for ECOWAS Drug Harmonization Committee, to make his presentation. Can we give him a big round of applause?
I go there. The chairman of this panel, other distinguished members of this panel, distinguished pharmacists here present, I must, on behalf of my organization, the National Drug Law Enforcement Agency, thank the organizers of this occasion by deeming it fit to invite my organization, not only because of the invitation of my organization, but it will go a long way in enhancing my knowledge on the drugs that we are supposed to police, which I have seen in several literatures that have been given to us yesterday. We have had problem here in Kano Command when some law enforcement agents delve into areas that they lack capacity to handle, largely because they do not have knowledge about the kind of drugs that they are supposed to police. Just recently, one of the law enforcement agencies, due to lack of knowledge, apprehended a pharmacist with diclofenac and now told the general public that he has arrested tramadol, tarnishing and besmirking the image of a pharmacist who has gathered this image over a period of years. But because of the good relationship that my organization have with the pharmacists and several others like Pharmacist Yaka says who have been helping the agency in actualizing the vision and mission of this organization, we had to come in and rescue the pharmacist by conducting a test along with NAFDAC, along with Pharmacy Council, and to show the entire world that the law enforcement agent lack knowledge in policing drug. Because before you start policing drug, you have to go to an academy. Before you start dealing with custom offenses or immigration, you have to go to academy and stay for 6 or 7 months. So you just don't wake up one day and start policing drug. And that goes to show that we are partners in progress. And we really hold you in high esteem. So it's a privilege to be with you today. And coincidentally, I'm the only one that is not a medical practitioner here because my background, I'm a lawyer. But it will better my understanding of these things. So before I delve into the issue of this drug dependency on how to curb drug addiction, let me give you a little historical perspective of what gave rise to this issue of ameliorating and the need of ameliorating drug dependency as well as policing drug. Towards the end of the 20th century, 2 crimes bedeviled the entire world: drug addiction and drug dealing and trafficking, maybe 3 crimes that civil liberty organization had to come to the rescue by writing to the United Nations organization to, as a matter of urgency and necessity, to enact laws, and the law that will now have to be co-opted by nations of the world, which gave rise to the Singles Convention of 1961 on narcotic drug, which is the first legislation that has to do with drug demand reduction, at the same time supply reduction. In 1971, there was the advent of new psychoactive substances that were not treated by the prior law, and which necessitated the UN again to make another convention known as the Convention on Psychotropic Substances. Then in 1988, there was the need to now galvanize these 2 laws together through the Convention Against Illicit Traffic in Narcotic Drugs of 1988, known as the Vienna Convention, which now made all subscribing members of the United Nations to form the Drug Control Organization, which gave birth to the NDLA. And the mandate that was given to NDLA is to inculcate and domesticate some of these enactments in these conventions that had to do with how to ameliorate the issue of drug abuse and the issue of supply reduction. And that is what informed the agency to now become part of its mandate to now conduct aggressive campaign against drugs to make the public know the dangers of drugs so that it will become more avoidable. That is in the area of drug demand reduction. While in the other one, it entails the arrest and of offenders who are either found in actual, implied, or constructive possession of drugs and now arraigning them before a court of law. So what this convention we're talking about, as far as those who are having the problem of drug dependency are concerned, is to treat their case as a medical problem, not to stigmatize them, to bring them closer to you so that you get to know what made them go into this drug abuse, so that you ameliorate their problem and provide solutions to their problems. But at the same time, these our laws now are faced with a lot of ambiguities to be corrected, with a lot of doubts to be resolved, with a lot of lacunas to be filled. Because the drug-dependent person is treated equally like somebody who is found in actual, implied, or constructive possession of drug, and they are given the same punishment. The punishment for if you are found in possession or if you are found with drug in abusing drug is not less than 15 years imprisonment and not less than 25 years. And you can see that, which means Nigerian legislation on drug needs to be corrected so that it will become in tandem with international best practices, which is more like treating a drug-dependent person like somebody who is having medical or health problem. Not to stigmatize him, as well as to respect his rights, not to mix him with criminals who are likely to bring wrong ideas into him. And that is what informed the United Nations Organization, UNODC, and the World Health Organization to bring about measures and steps to be taken in ameliorating the problem of somebody who has already found himself a victim of circumstances of drug abuse. In Nigerian legislation, even the Constitution now says, for instance, that you're having problems all over in the legislative aspect of the law, whether nationally or locally. If you are under the age of 18, there is no need for anybody to look for your consent to take you under drug rehabilitation. But if you are more than that, we need your consent. You understand? So now, the issue of how do you now ameliorate this problem? If in a place where there's availability of these drugs, there is likelihood that those who are living in that environment are prone to become drug abusers. So what we do, along with other regulatory bodies like NAFDA, Pharmacy Council, and so on, is to make this drug only available for medicinal use only. How do we do that? In our borders, in our seaports, in our airports, we police these drugs, as well as the precursor chemicals, ephedrine, pseudoephedrine, that are used in manufacturing some of these drugs. NAFDA have gone an extra mile to even issue only few individuals licensed to import such precursor chemicals as well as those drugs. Because it was found that some of these people that apply for these licenses, their need for production of these drugs is not more than perhaps 5,000 kilograms, but they will import 10,000 kilograms. The remaining one they will give men of the underworld or to give some clandestine laboratories. So these steps have been effectively policed in the airport, in the seaport, in the border area, so much that recently you must have heard that the NDLA and Customs have apprehended more than 150 containers of tramadol. This tramadol will have come to Kano. This Kano, why I said this is the right choice and this is the right venue for this occasion is that 2 years ago, Kano have been, statistics have shown that Kano is the highest state with drug abuse. But with the cooperation and collaboration that we are having with distinguished pharmacists like you here, the Pharmacy Council and NAFDAC, NAFDAC is now Kano is now number 3. It's number 3. Third to Lagos, Lagos number 1, Oyo number 2, Kano number 3. Since the ban of codeine in 2018, all of us sprang into action, all the regulatory agencies. Because the NDL, to show you that the drug is actually reducing. In the area of cough syrup with codeine, NDLA apprehended almost about 8 tons in 2016, representing 62%. Then in 2017, it came down to 3.9 tons, representing almost about 20%. Then what happened when the government now banned cough syrup with codeine? It came down to 1.8 tons, representing 13%. It has started coming down. The major drugs of abuse here in Kano are tramadol and cough syrup with codeine. You cannot go to the street of Kano now and see fake cough syrup with codeine because it's very expensive to come by. And similar tramadol. A carton of tramadol is almost about 16 million naira now. So in 2016, NDLA seized about 25 tons of tramadol, representing 62%. Then in 2017, it came down to 8 tons, representing 22%. Then in 2018 and 19 now, we're not even talking about tons. We only see about 10 kilograms, which is just about 0.02%, which means we have made it very difficult for people to even see. It's only when you see the drug that you tend to abuse it. But if you don't see the drug, you cannot abuse it. Now, tricksters have started taking over the field of the sale of drug. What they do now is to bring a tramadol, to call an intending buyer, and put some few original tramadol on it, while the underneath will have only Panadol. That is what is happening. So most people who are even thinking that they are taking tramadol, they are taking Panadol. And this is because of the cooperation we are having with all of you here. So one of the first stages that you do to treat the problem of drug dependency or drug abuse is detoxification. That is to make it abstinence, to make it more avoidable to the person, so that even if he has that craving desire to take the drug, you take it away from him by discouraging him, by showing him the different types of drugs and the impact that it's having on his own health. Then the second one is diagnostic tests that we do to the person. Sometimes we engage in screening the urine of that person, whether we can see drug in it, using the United Nations reagent given to us by the United Nations Office on Drug and Crime. But I said that one of the other steps that was introduced by the World Health Organization and UNODC towards ameliorating the problem of somebody who is already under dependency is the issue of evidence-based procedures. That is, to employ procedures that have been tested in other countries. And that is why UNODC, NDLA, and NAFDAC have been having capacity building program for more than 5 years now, trying to reorient those who are law enforcement agents as well as regulators on the best international standards of ameliorating the problem of somebody who is into drug dependency. Another issue is harm reduction. Though harm reduction is not welcome by most Nigerians, harm reduction is a situation where if somebody cannot do without the drug, you bring a substitute to the drug. Like for instance, cannabis sativa now is having almost about 3.5% content of tetrahydrocannabinol. And tetrahydrocannabinol can stay in somebody's body for more than 3 months. Now, you have been hearing that one of the governors was even saying that Nigeria should start exporting Indian hemp for medicinal purposes, which was violently opposed by most Nigerians. Why that is violently opposed is because the kind of cannabis that we have here, the tetrahydrocannabinol that is involved in that cannabis, is 3.5%. But the one that is allowed in other developed countries only having about 0.02%. You understand? So what people are ascribing is that if somebody cannot do without the drug, why don't you introduce the one that is having less addictive substances in it? So one is one of the this that we do also to detoxify these drug-dependent persons. Then community participation. Community leaders, NGOs, pharmacists, policymakers, regulators, all of them must participate. Sometimes even the victim himself should participate in this kind of issues of providing solutions to this problem of drug dependency. So there are many of those things that have been lined up by the United Nations organization. But the problem we are having in NDLA is that we do not even have the facility that can accommodate the teeming number of people who are requesting the services of NDLA. The facility for rehabilitation of NDLA can only accommodate only 16 people. It cannot even accommodate female drug-dependent persons. And statistics so far have shown that in 2 years ago, out of every 5 persons, 4 people are male who take drugs. Only 1 person is a female. Now the thing has now come upside down. Now out of 5, 4 are females, 1 is a male. And we do not have that facility for rehabilitating this female drug-dependent person. In the whole of Kano, that has the population of almost about 9 million people, we only have 2 rehabilitation centers. One in NDL that could accommodate 16, the other one in Kiru, which is not regularly being patronized by the government. That now led to people now who engage private sector now, who do not even have the requisite know-how, who do not even have the stages of rehabilitation to take over the rehabilitation business from government. Some of them will go an extra mile of putting leg chains on this drug dependence or handcuff. And this is what is discouraged by the United Nations organization. Because one of the modalities that is introduced by the World Health Organization is that there cannot be a conflict between law enforcement and rehabilitation. Because the United Nations International Convention on Civil and Political Rights has guaranteed so many rights to the drug-dependent person who is undergoing counseling. He has right to life. He has right to dignity of his person, which entails not to allow his body to be subjected to inhuman treatment, servitude, or slavery. While under incarceration, he should be given medical services. He should be allowed to roam around within the premises of the office where he's undergoing rehabilitation. But in those private ones, you don't do that. Already, he's already on handcuffs or leg chains, which is a gross violation of his rights. You know, nowadays, in this democratic dispensation, a suspect himself has more rights than even the regulator or law enforcement. So much that the Administration of Criminal Justice Act itself, 2015, says we should not be addressing a suspect as a suspect or an accused person. We should dignify his name by calling him subject. Huh? He's a subject. Or better, I call him a defendant. So whatever we do here in NDLA in terms of drug rehabilitation, drug reintegration, we do it in tandem with international best practices which are more inclined toward respecting human rights and human dignity. So in a nutshell, not to take away our time, now that I have already stated all the modalities which informed the topic of this discussion, I would want to once again thank the community pharmacists for deeming it fit to organize this occasion, especially in Kano, and it wouldn't have been more timely than now when statistics have shown that 14 million people, Nigerians, are into drug. So many people are making a lot of statistics, even those who are not even supposed to do that. Recently, I think the DG, with due respect, the DG Nabda, when she came to Kano, she was vehemently opposed. When she said 70% of people of Kano are taking drug, probably it was a slip of tongue. It was not deliberate. Though actually I came to her aid when that happened. So once again, distinguished members of the community pharmacists, I once again thank you for giving me an opportunity to speak in this occasion. Thank you very much.
Thank you very much, Dr. Ibrahim Abdul. He certainly deserves a bigger round of applause. Yeah, he was speaking. Yes, he's not a medical person. He's actually a lawyer. But then he proved to us, all of us that are here, that he truly knows the job. I was wondering if we gave somebody from NDLE a chance to speak about how to manage drug abuse or how to disrupt it in a very innovative way. Whether he wouldn't tell us is from using their long guns that we see them carry about and then using the handcuffs. But it appears they appreciate that it is more of a medical issue that requires alternative solutions that they too have been involved in. And they are not working alone. They are not working like a Nigerian organization. They are working with the UN. They are working with WHO. They are partnering with NAFDAC. They are involved in so many things: counseling, detoxification, diagnosing, evidence-based procedures, even community participation, even things like rehab centers. And then they have issues, partly because maybe funding, partly because maybe they shouldn't even be the ones to do most of the things that we're expecting them to do, but they definitely have a role. But it's nice to know that they don't think, for instance, that arresting, prosecuting will be a solution. Yes, there has to be some deterrent, but then they also have to treat it as, in fact, treat the victims as truly victims. Another big round of applause for him. Some of us may have questions for him, but he's truly in a hurry to accompany their boss to another event, and he must leave now. I do not know if you have truly any special concerns. We'll find a way to pass the information on to them, maybe by way of a communique. But then it's been nice to have Dr. Abdul. On your behalf, I'd like to thank him and to wish him well as he leaves. Thank you. So we quickly move. Yes, we are supposed to have like 2 or 3 hours to do this session. Suddenly they want to cut it to 1 hour, which, although it looks impossible, but we try to see what is practicable, hoping that many of you will still remain here as we move on. It's my honor, privilege, and pleasure to now invite our own Monica to please make her presentation. A big round of applause for her. Can the slides come on?
The chairman of this session, senior colleagues here present, chairman of Acpn, delegates, good afternoon. Let me first appreciate the Acpn and thank them very much for this invitation to speak on a topic that has touched each and every one of us here, directly or indirectly, by virtue of what we do or by virtue of what we are supposed to do. Can I have the next slide? My presentation will touch very quickly on the scale of abuse after defining drug abuse, talk about consequences, global concerns, the global situation, and then come back home to look locally, and then home in on community practice. The next slide. There's a definition of drug abuse from the WHO. And for the purposes of this presentation, I highlighted some specific words. It's defined as a maladaptive pattern of use indicated by continued use despite knowledge of having a persistent or recurrent social, occupational, psychological, or physical problem that is caused or exacerbated by the use, or recurrent use in situations which it is physically hazardous. So the words for me that spoke to me were the maladaptive pattern, continued use, where there is a problem that is caused or exacerbated. The next slide. Now, when we talk about the scale of the problem in Nigeria, there is a publication from the UNODC that speaks to the scale of the problem in Nigeria. If you've not had the opportunity to go over that document, it would be useful and helpful to look through it because it speaks to several of the concerns that we have, as referenced by the NDLA State Commandant, and also, I believe, yesterday during your session. So that there is a problem in Nigeria is not under contention. Can you move to the next slide? Next slide, please. And the next one. I'm trying to make the best use of time. So let's look at this slide. And the substances or drugs of abuse as captured in that report. Because when you talk about drug abuse, you have to home in to the specific problem within your jurisdiction. Drug abuse in America might not be the same as drug abuse in Nigeria, neither would it be the same as in Europe. And I think this slide captures it. You see 10.6 million cannabis, 4.6 opioids. Note that the US declared an opioid epidemic. For us, cannabis leads it. 2.4 talks about cough syrups. And I'll talk a little bit about that later. 481,000 tranquilizers and sedatives, 340,000 ecstasy, 300,000 solvents and inhalants, 238,000 amphetamines and prescription stimulants, 92,000 cocaine. Now, if you look at that, it tells us something. When you talk about drug abuse, people rush to talk about prescription. Cannabis is not prescribed, but it's a problem. Cough syrups, for the most part, codeine containing, were not prescribed at that time. Solvents and inhalants are not prescribed. So within that space, as a community pharmacist,
Which of these are you involved in? And you can begin to position yourself in that space. The next slide, please. So I've extracted some of the highlights. You have a global prevalence of 5.6%, Nigeria 14.4%, off the scale as usual. Yes? 14.3 million people as at 2018 are affected by this problem. And from this document, it says 1 in 4 drug users in Nigeria is a woman. 2.5% as against 2.3% for men. Statistically, is that really significant? I don't know, but that's what it says. And it goes further to say the women are using mostly codeine-containing cough syrups. 1 in 5 high-risk users inject. Luckily for us, culturally, we are averse to injections. So I think it has held us in good stead in this instance. Sorry, the technology, I'm getting messages on this phone. Tramadol and codeine, specific to us and very interesting to think about the reason why tramadol and codeine are indicated as drugs of abuse in Nigeria. And I have my own thoughts, might not be supported by the evidence yet. For the most part, tramadol has been the only available pain medication within Nigeria, for the most part. When you're talking about the oxycodones, the hydrocodones, the morphines, we all know that there is limited access within our country. And that would account for the reason why, to my mind, tramadol is up there. Because if you look in developed climes like the US of A, most of the drugs of abuse are prescription drugs which were prescribed legitimately for pain. So that would explain why. Now the codeine, we begin to wonder, because at the time, these products were over-the-counter products. Codeine containing cough syrups, when you discuss with people, and I've had several discussions, I'm told is used not only for addiction, but also as a vehicle. Now the issue with banning products, people look to other issues. So when you talk about drug abuse, it's more than just the drug. There's a lot that goes into it. Factors that encourage drug abuse are many and far and in between. So currently, Nigeria is ranked 5th in the world when you talk about suicide, with about 6 suicides every month. This calls into question how we handle mental health, how we handle behavioral health, and the cultural issues that we have as a nation. Next slide. And so I wanted to bring this out. You talk about drugs of abuse. There are those that are prescription. There are those that even currently as we speak are over-the-counter products. Then there are the illegal drugs or substances which my colleague from the NDLEA also mentioned. Next slide, please. I tried to bring out some. You notice I asterisk codeine because recently added to POM, but tramadol is there. Fentanyl, morphines, hydrocodone, oxycodones, then the depressants and stimulants. When you look at diazepam, alprazolam, and the zolpidem, you begin to wonder, well, these are the realities of our time. The stimulants are also there. The dextroamphetamines, dexedrine, methylphenidate, and the methylamphetamines. Next slide. The over-the-counters, I've listed a few. Codeine-containing cough syrups, unfortunately, but always mentioned. But chlorpheniramine is being mentioned. Caffeine-containing pain medications are being mentioned. These are very much over-the-counter. And pseudoephedrine-containing formulations. So as a community pharmacist, and you look at that list, and you begin to relate, and you begin to understand, and you begin to see how the practice can affect, and impact. Consequences of drug abuse, I don't want to spend time on that. Next slide. Economic, legal, medical, and social. And I think my colleague from the civil society can speak a lot more on the social aspects. I wanted to move globally. Next slide, please. After this, talking about a global concern. Let's not be deceived that only Nigeria has this problem. There's a lot of collaboration going on globally, and the efforts of the UNODC in this area have been well documented. Currently, there's even a UN drug control program working with the WHO, which has an initiative on primary prevention of substance abuse. And the USA declared an opioid epidemic in October of 2017. Most of what they saw was linked to what happened after people were prescribed the oxycodones, the hydrocodones, long-acting, short-actings of this world to handle legitimate medical concerns. After they got through the pain, many of these patients continued to use these products and get access. Now, how do you get access to a prescription product in a highly regulated country as the USA? And so that is one of the reasons why recently you hear about big companies, multinationals, being cited by the FDA for their role in the epidemic crisis. And trust me, it's just beginning. But what that did, and the emphasis the US has now placed on the opioid epidemic, resulted from the shift. Because the prescription products, you had to see a physician, you had to get a prescription, you had to go to a pharmacy to dispense. Levels of controls that were supposed to be in the system to mitigate this happening. So as a doctor, you prescribe when there's a legitimate use, but after the injury, is there still a legitimate use for you to continue to prescribe? The pharmacist that is dispensing, I worked in the US, at a point you would question whether the prescription was legitimate. So you had mills, clinics that served as mills for financial benefit would continue to provide these prescriptions. When you didn't now have access, people now shifted to the more cheaper heroin, which was easier to get than the oxycodones and the hydromorphones. And so the peculiar problem in the US is very, very specific. But the next slide. In managing drug abuse locally, we can learn from what they put in place. This is a slide from the NIM. And how do you prevent opioid misuse? It talks about talking about it. At one point, even talking about drug abuse. I think pharmacists have been at the forefront, and I think the ALPS has been at the forefront. Where are the Alpians in the room? Congratulations, a round of applause for ALPS. You won't clap for us. Talking about drug abuse and pharmacy, community pharmacy, taking on this talk long before it became national discourse. So we positioned ourselves in the right place. Talking about being safe, understanding pain, knowing addiction, and being prepared. Let me talk a little bit about the interventions, next slide, that were put in place by the US. Next slide, please. They had prescription drug monitoring programs that were put in place. And physicians as well as pharmacists were encouraged to participate in that drug monitoring program. We talked about education and training. I was smiling when Larry Balle was delivering his paper, where he said 1.6% linked to drug abuse. That is abysmally low. And then 1.1% to capacity building in the surveys that they had. These are areas of concern for us. And if we're to really play in this area, we must embrace this. And I'll speak a little bit later about it. Providing comprehensive treatment for pain and substance use disorders, ending the stigma, co-prescription of naloxone. For opioids, there is naloxone that is used as an antagonist, and encourage safe storage and disposal. Next slide. I never forget that we are regulators. And a lot of time we get blamed for everything and anything that happens. But there are limitations, and we are all involved in the process. So I just brought out the NAFDAC mandate, and I highlighted some parts. Importation, manufacture, distribution, sale, and use as relates to drugs. We want to ensure compliance to the necessary regulatory measures that have been put in place, and there are quite a few. We talk about having permits to import, permits to clear, talk about national control of some substances, even when there isn't international control. We talk about monitoring, we talk about inspection, pharmacovigilance, and I mentioned the control. Those are some regulatory measures. And we can expand on these. But let's home in to the community practice. Next slide. So, training and education. And I was smiling in the last session, a lot of talk about training. As pharmacists, you must understand, first of all, the products of addiction. You must be able to recognize when you see addiction. So how do you know when a patient walks into your pharmacy if this person is addicted to any substance? Most of us operate within communities, and you have people coming in for repeat, will I say prescriptions, or for repeat encounters. And you see a trend. You see certain substances that you begin to wonder, why is this person buying so much of X? And as a pharmacist, what do you do about it? So we need to train ourselves on the products. We need to understand the science behind it, and we need to be able to recognize when addiction, and then see when there is a change in trend. The issue with codeine has caused a shift. We need to document that shift. Because if you don't take care of the social issues that surround addiction and drug abuse, you move from one substance to another. We need to collate data for references and impact policy that will be drawn out in this space. And so the discussion about the digital realm within community practice, documentation, very key. Without documentation, you can't do this. So also as part of this, maybe putting in a quality management structure across community pharmacies will help us as you move forward with this. You have to identify and collaborate within the community. This is being done. It can only be ramped up. Okay, next slide. Awareness and sensitization campaigns are also being done. And we can look to build an effective feedback system. If you don't feedback and collate, you won't know the trends within areas, you won't know the trends within geographies, and we won't know the trends within Nigeria. So it's very necessary we build that feedback, and we identify with rehab centers. So if within your community you see a problem, who is your first point of contact? Who would you refer somebody to if you feel there is? Do we know? I know there are not many centers, but there are some that exist. And there's more work being done by civil society in this area. So being able to advise within your community on what to do in a professional manner would also help us as we address this situation. Understand the drug dynamics. Build and improve patient-pharmacist confidence. You can only build confidence when you show somebody that you know a lot more than they do on a particular topic. And pharmacists are well positioned to do that. Awareness and sensitizations, as I said, are ongoing. Next slide. Providing guidance and counseling in pharmacies. You're talking about pharmaceutical care, and this is an area where we can also play. In order to play in guidance and counseling, there's a measure of training that you must undertake to do that. Next slide. And then, as I said earlier, drug abuse, there's no one agency, there's no one organization, there's no one group, but collectively, civil society, other healthcare professionals, law enforcement, regulators, collaboration, continued collaboration in that effort will stand us in good stead. So with that, I will end and just advocate that this is a call to greater action by community pharmacists. I thank you for taking time off to bring up this topical issue, and we can only move forward and make greater strides. Thank you very much. Good afternoon.
Another big round of applause for
Emzor
Monica.
paracetamol. Feel better.
You can see the reason why yeah, the presentation
Malaria.
does not need any summarization because I think she
Lock it
delivered
down.
Not just like a
Lock
regulator,
down
but
malaria
like a teacher.
with Lockmal Combi. Lockmal
appears as
quickly
if
and
we are
effectively clears malaria parasites from the body
very
and
good hands.
makes you malaria free.
Any questions or any
Lockmal Combi, a brand of artimethyllumethantrine, comes with 12 bonus tablets of Emzor paracetamol. Lockmal, lock down malaria and feel even better.
The family of a con has been taken hostage by an evil-looking creature.
When Amatem Fort appear, malaria run for cover. Amatem, thank you. Amatem Fort are just soft gel capsules, tablets for adults, and suspension for Pekin. Amatem does not eat your body and are very easy to use. Remember how Amatem Fort are just scratch pin to confirm the original and are just soft gel capsules. Amatem, say no to malaria.
So
yes
they
to
have
life.
practical experience in first as a doctor, as a psychiatrist, but then he's representing this organization, the Suicide Research and Prevention Initiative, and they've been generous with providing services to us at the last Academy symposium on drug abuse. I think one of your representatives was there, and he truly contributed. So let's welcome him with a big round of applause and listen to him attentively. Dr. Tunde.
The chairman, standing on existing protocol, it gives me pleasure to be here, and I'm happy that people are beginning to pay attention to mental health in general, because even the WHO has said that by the year 2020, mental illnesses are going to be the second leading cause of disease burden globally. And it looks like, it appears we're there already. The first message I received this morning was of a young man who was found dead in his hotel room. And postmortem revealed that he died of drug overdose. Sometimes when I look back in life, Pharmacist Okwa is here. I grew up in Festac. And I wonder how I survived that town, because right now I see many of the young people that I grew up with in my clinic. So I've been asked to talk about innovative management of drug and substance abuse with a focus on suicide prevention. My name is Tunde Fadikwe. I'm a consultant at the Lagos University Teaching Hospital, and I'm also a member of the Suicide Research Prevention Initiative of Nigeria. So we've been told that we have limited time, so I'll just run through the slides. First, I will talk about mental psychoactive substances, and then go on to talk about suicide. So I start with a scenario. This is a young man I saw some time ago, a 24-year-old single male who had incomplete university education. He had dropped out of university in his final year, and unknown to his parents, he had been asked to withdraw 5 years earlier. He had also been involved in use of psychoactive substances, especially cannabis, without the knowledge of his parents. And so one night, after he had an altercation with his elder sister, and under the influence of alcohol and marijuana, he decided to ingest a pesticide. And I know that your guess is as good as mine. Sniper seems to be what the young people are taking now to end their lives. We all know what a drug is, so I don't need to dwell on that. Please, next slide. But it's important to note that there's a difference between a drug, which is any substance that you can ingest through any of the surfaces or mucosa in the body, while a psychoactive substance is any drug or substance that acts primarily on the nervous system and alters brain function, causing changes in the way you perceive things, your mood, consciousness, and in behavior. Next slide. Substance use disorders are medical conditions in which the use of one or more substances leads to distress that is clinically significant and is characterized by mental, physical, and behavioral problems. There are different classifications. Next slide. We have those that depress the central nervous system, depress respiratory system. There are those that stimulate. So, for instance, things like cocaine, like cola nuts. They are the hallucinogens that cause hallucination. So people begin to hear voices when there's nobody there. And then there are those that we refer to as solvents. And there are those that I've decided to characterize as the unusual ones, you know, especially now that so many substances have been banned. And then these are commonly used in people of low socioeconomic background. So you find people presenting to you with complaints of sniffing from the pit latrine or storing urine for days for them to consume, you know. And then, so as a young resident, a couple of years ago, we found out that patients who are on treatment had this habit of requesting for Lacasera or Coca-Cola. And then one day somebody caught them, you know, so they shake it, they open it, and then they sniff the gas. They inhale the gas. Psychoactive substances can also be classified as licit or illicit, even though now we're finding that there are some substances, for instance, there are some drugs that are prescription medication that can be obtained in illegal ways. So, for instance, patients who want to abuse opioids, pentazocine, forge a doctor's prescription and approach the pharmacy. What is the motivation for use of these substances? It will differ. Next slide, please. Yes, next slide. Thank you. It will differ and depends on two broad categories. So sometimes people use these drugs to feel better. So they are seeking a sensation, which is commoner among young people. And then there are those who use these substances to avoid feeling bad. And so the motivation is important in order to be able to help the individual deal with the concern. People move through different stages before they become dependent. Next slide. On a psychoactive substance. So there are those who start from experimenting what is in this thing, and then they move to social use. So they use maybe in a group or with friends or because they have to be among. And then there are those who use it to achieve specific purposes, which is the instrumental use. And then they go on to compulsive use, which means that they cannot function without it. Again, as an offshoot of the message I received this morning, I was having a discussion with someone, and somebody told me that they had a colleague who they noticed would just leave his workstation, go to the car park, and by the time he comes back, he's reeking of alcohol. I mean, it's obvious, and then they would find bags of small bottles of what these drugs, alcohol that they sell in packs, Kerewa, Alomo bitters, in his bag. Why are substances addictive? Can the presentation come up? Okay. So why are substances addictive? Now, science has shown us that the brain has a reward system. And that reward system accounts for most of the pleasure that we experience from the normal, natural things of life. So, for instance, when you eat, when you have sex, when you drink. But this same reward system is also activated by psychoactive substances, drugs. And the belief with addiction is that with repeated use of these drugs, they hijack the reward circuitry so that the person always looks forward to experiencing that positive effect that they get. And we believe that this is mediated by the action of dopamine. Psychoactive substance use is prevalent all over the world. So, I mean, we once had a young man whose father decided to discharge him. I wanted to take him to one of the Arab countries because he believed that the son would not have access to drugs. And I told him it is a lie. There's nowhere in the world that you will not find these drugs. In fact, as a matter of fact, I mean, some of the opiates grow easily in all these places. And it affects people irrespective of their age, their race, their cultural or economic background. And the effects are overwhelming, not only for the individual, but their families, the society, and the economy. The previous speaker has talked about the burden, so I'm not going to dwell on that. Next slide. Next slide. Next slide. Okay. Next slide, please. So we go on to why people use psychoactive substances. And I will say that there is no, next slide. Next, 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 next. Please go on. Okay, yeah. So, yes. So there's no single cause of why people use or reason why people use psychoactive substances. A lot of times, like many mental health conditions, the cause is multifactorial. So there are so many things. The genes, the role of the environment, so people copy. I mean, if someone has a father who drinks a lot of alcohol, I mean, it's only natural because there's usually alcohol everywhere in the house. So the person has to start from somewhere. And if the father uses alcohol and the son at 19 decides to begin to use, it will be very difficult for the father to correct the child. So alcohol is usually very available in the house. Studies have linked the use of psychoactive substances to growing up in chaotic homes, in homes that have very large families. Next slide, please. There's also the role of peers. So when I was growing up, I visited one of my uncles, and he told me to meet him at the stadium. This was in Ogun State. And when I got there, he was with his friends. They were all young, and they asked what I was going to drink. And I told them I wanted the soft drink. And they said, no, that you are going to spoil our table. You know, and I insisted that that was what I wanted. And he said, well, if that's the case, then my uncle should give me transport money to join his wife at the shop. So I decided to leave. Now, that is the problem with young people, because at the age of adolescence, you are trying to identify where you belong to, who you are. And so sometimes young people have to do what their peers do so that they can identify with them. If they don't do that, they end up being confused. So we call that stage identity versus role confusion. And it's a very, very dangerous period in a young person's life. And it's the period where many young people begin to use psychoactive substances. Next slide. There's also the, next slide. Next slide. Okay, so there's also the problem with role modeling, who we refer to as role models. So I've talked about the role of parents in the society. So if you look, the picture on your left is of a popular musician called Timaya. And you can see what he has in hand, shisha. And in one of his songs, this guy actually said that they say they smoke marijuana. This marijuana, they make me the hammer. And in actual fact, cannabis gives people ideas. I tell students that cannabis helps you to do what you want to do. So you find them coming and arguing with you that, oh, when you use cannabis, it helps you. Yeah, but you need to also look at the negative parts. So for instance, you take cannabis to read. Then if you want to recall what you have read, you need to use cannabis. It's called state-dependent learning. You know, so, and then there's the issue of science students. Even though the song was really criticized, I thought that maybe people should look at the positive, because many parents did not know what their children were doing. You see children carrying a bottle, and you think the child is drinking water. But as a matter of fact, the person has mixed it with codeine. So I thought it was an opportunity. And then there's also the issue of, next slide please, of access. So there are few things that determine whether people will use drugs. The fact that it is available, it is accessible, it is affordable, and we allow it. So if you live in a community where it's okay to drink alcohol, I've never been to the South, but people say it's about the South that it's all normal to drink alcohol, whether you're male or female. So, and then if you look around us, for those of us who come from Lagos, go to the bus parks, you see sachets of spirit, 40% alcohol, small bottles, 40% alcohol everywhere. So we have an epidemic in our hands. Unfortunately, the representative of the NDLA has left here, but I think that there's a lot more to be done in terms of regulation of these things. Also, I mean, culturally in some places, if you are from the part of my world, if you buy a car and you take it to your village chief, then you have to accompany it with a bottle of Ego Schnapps or whatever so that they can pour over the engine. Or if you're in the road transport business, where they believe in Ogun. And then there's the issue of advertising. Next slide, which makes it attractive. Next slide. Recently, I saw a documentary on BBC. Again, the head of the NDLA has left, and it was focused on Kano. So Kano is coming into the picture again, with children living in the slums, picking from the dump. And so you will see in that video, they would hold sachets of pure water, and they will be blowing into the bags. And what those bags actually contain are solvents. So they put glue. And you think that they are drinking water. So you see them, they are blowing into it and inhaling, little children on those dumpsters in Kano. So, I mean, it's almost similar to what is depicted in this. And so you find that drug use is higher in low socioeconomic groups and people with low income. And people from low income backgrounds tend to use cheap and locally made substances that are prepared illegally. And I think that this is the same thing from all over the world. Recently, I met a colleague who is from Mexico, and it was the same pattern. Use of glue, sniffing glue, petrol, solvents is prevalent in the northern part of their country. Another, next slide, problem why we have increased use of substances is the fact that we have lost our values. I mean, so we now tend to copy from the developed world. And just to mention that right now, there is also the problem of use of synthetic cannabinoids. So when you see those videos where children are behaving like zombies, it's because most likely they've ingested these synthetic cannabinoids. I don't need to tell you about the routes of administration, but I'm going to highlight, next slide, the major complication, which may be physical, maybe psychiatric, forensic, social, economic. And as part of the psychiatric or psychological complications is suicide, which I'm going to go into. Suicide is the act of deliberately taking one's life. And a suicide attempt is used to mean any non-fatal suicidal behavior, and which may include self-inflicted poisoning, injury, or harm. There are different types. Next slide. As described by the sociologist Emil Durkheim. And he described anomic suicide, which is suicide that is due to a breakdown of social equilibrium, bankruptcy, loss of job, and family. And I believe that this is one of the reasons why many young people are taking their lives in this country. There's the altruistic suicide, where people kill themselves in the interests of the group. And this you will find in cases of suicide bombers, for instance. So they kill people in the interest of their group. And then the fatalistic type, where society sets an expectation on the person. And you find this in places like Japan, where because the person thinks that they've done something, they decide to take their own lives. And there's egoistic, which is caused by social isolation. The burden, next slide, is such that suicide can affect, we see children who have attempted to take their lives, whether because they have a chronic condition, maybe cancer, but the fact is that they have attempted, previous slide, to take their lives. It is irrespective of your income. It is irrespective of gender, and it is irrespective of race. It's a global global epidemic, and it is such that every 40 seconds, one person takes their life. And for every one person who attempts to take their life, you have 20 more people who have attempted it. The previous speaker talked about the fact that 6 people die every month. But the truth is that we don't have data. So I can assure you that there are many more people who die and would not be reported, especially because it is stigmatizing. If you want to get married and there's somebody who has killed somebody in themselves in that family, it's very likely that your parents will discourage you from marrying from that family. And among young people aged 15 to 29, it is the second leading cause of death. Like I said, it is underreported, and the low middle income countries like ours, next slide, bear the most of the burden of suicide globally. It impacts on families, their friends, and the communities. Next slide. Next slide. In terms of ratio, it's commoner among males because males tend to use more severe means. So they are the ones who are more likely to hang themselves or jump from a height or use lethal weapons like guns. In low middle income countries like ours, the ratio is put about 1.6 to 1, while in high income countries, the ratio, male to female ratio, is put at about 3.5 to 1. So it's higher outside of here. Next slide, please. Now, some of the reasons why. No, go back. Go back. Go back. Go back. Oh, okay. You are going forward, but it's okay, no problem. Yeah, it's okay. Yeah, so some of the reasons why the rates may differ is because culturally, especially in this environment, females are more